Segmental autoimmune pancreatitis. Contrast-enhanced axial CT, left image, shows a segmental region of low attenuation enlargement of the pancreatic tail and body arrows, with loss of the normal ductal architecture. T1 weighted unenhanced MRI, right image, shows a corresponding segmental loss of the normal T1 hyperintense pancreatic signal, with effacement of the pancreatic duct in the affected body and tail. The differential diagnosis for this appearance would include pancreatic lymphoma, less likely pancreatic adenocarcinoma as there is no ductal dilation. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Autoimmune pancreatitis is the pancreatic manifestation of IG4-related sclerosing disease. The typical imaging appearance of autoimmune pancreatitis is diffuse, sausage-like enlargement of the pancreas with loss of lobulation. A capsule-like rim may be seen. The appearance can also be focal or multifocal, which may mimic a pancreatic mass. Treatment is with steroids, which can lead to a complete resolution. Immunotherapy-related changes. Immunotherapy can lead to episodes of pancreatitis, which may be clinically occult and can result in pancreatic atrophy. Overview of pancreatic neoplasms. Benign, many small cysts, elderly women. Malignant potential, surgical lesion. Single or few large cysts, middle-aged women. Young women, heterogeneous, prone to hemorrhage. Malignant potential, elderly males. 80 to 90% of pancreatic tumors. Rare, aggressive, can cause fat necrosis. Mucinous cystic. Metastasis. Most are benign and small. Causes Zollinger-Ellison syndrome. Cystic epithelial neoplasm. Solid epithelial neoplasm. Solid pseudopapillary tumor. Gastronoma. Lymphoma. Endocrine neoplasm. Cystic neuroendocrine. Ductal adenocarcinoma. Solid pancreatic epithelial neoplasms. Adenocarcinoma. Ductal adenocarcinoma. Pancreatic adenocarcinoma of the head causing the double duct sign. Two coronal images from a contrast-enhanced CT show marked dilation of the common bile duct (CBD), moderate dilation of the pancreatic duct (PD), and the obstructing, ill-defined hypotenuating mass in the pancreatic head (red arrows). Pancreatic ductal adenocarcinoma accounts for 80 to 90% of all pancreatic tumors. It is typically seen in patients over age 60, with a slight male predominance. Risk factors include smoking, alcohol use, chronic pancreatitis, and family history of pancreatic adenocarcinoma. A pancreatic mass protocol CT includes early arterial phase, late arterial phase, pancreatic phase, and portal venous phase images. The late arterial phase, pancreatic parenchymal phase, has the greatest conspicuity for detecting the hypoenhancing tumor against the background enhancing pancreas. The most common location for a tumor to arise is the pancreatic head, where it often causes ductal obstruction. Pancreatic adenocarcinoma is usually hypoenhancing relative to pancreatic parenchyma and results in upstream, towards the tail, ductal dilatation and parenchymal atrophy. The double duct sign describes dilation of both the pancreatic duct and the CBD due to obstruction by the pancreatic head mass. Since pancreatic adenocarcinoma is almost always associated with a dilated pancreatic duct, an alternative diagnosis should be strongly considered if there is a pancreatic mass with no ductal dilation, such as autoimmune pancreatitis, groove pancreatitis, cystic pancreatic tumor, neuroendocrine tumor, duodenal gastrointestinal stromal tumor, GIST, parapancreatic lymph node, pancreatic metastasis, e.g., renal cell, thyroid, or melanoma. Lymphoma. Conversely, if a dilated pancreatic duct or double duct sign is present but no mass is visible, one should still be suspicious for pancreatic adenocarcinoma. Approximately 10% of lesions will be isotenuating relative to pancreas and/or difficult to visualize on a portal venous phase CT and thus extremely difficult to detect. When evaluating whether a pancreatic neoplasm is resectable, it is important to evaluate for any vascular variants and to determine tumor involvement of the nearby vessels, SMA, including first jejunal branch SMV, portal vein, celiac axis, common hepatic artery, and splenic artery. Abutment. Less than 180 circumferential contact with vessel. Encasement. Greater than 180 circumferential contact and/or deformation of the vessel. Limited extension to the duodenum, distal stomach, or CBD does not preclude resection, as these structures are resected during a Whipple procedure. Acinar cell carcinoma. Acinar cell carcinoma. Axial left image and coronal right image contrast-enhanced CT shows a large pancreatic tail mass with mixed soft tissue and fluid attenuation and surrounding fat stranding. The mass effaces and possibly invades the greater curvature of the stomach and left kidney. Acinar cell carcinoma is a rare, aggressive variant of pancreatic adenocarcinoma, exclusively seen in elderly males. The malignant cells produce a large amount of lipase, which leads to the clinical triad of lipase hypersecretion syndrome, subcutaneous fat necrosis, bone infarcts causing polyarthralgias, and eosinophilia. Cystic pancreatic epithelial neoplasms. Solid pseudopapillary tumor, SPT. Solid pseudopapillary tumor. Axial T2 weighted left image and post-contrast T1 weighted right image MRI demonstrates a mixed solid and cystic lesion arising from the tail of the pancreas with heterogeneous internal enhancement and AT2 hypointense, enhancing capsule arrows. Solid pseudopapillary tumor, SPT, formerly known as solid and papillary epithelial neoplasm, SPEN, occurs in young women and children and is nicknamed the daughter tumor. It may rarely cause abdominal pain but is often asymptomatic. It is more often located in the tail. It has a low malignant potential and is typically resected. On imaging, SPT appears as a large mass with heterogeneous solid and cystic areas. Hemorrhage is typical. SPT features a capsule. The only other pancreatic tumor with a capsule is mucinous cystic neoplasm, MCN, below. Mucinous cystic neoplasm, MCN. Mucinous cystic neoplasm. Axial unenhanced CT shows a cystic, peripherally calcified mass in the tail of the pancreas arrow. Pathology at resection showed borderline malignancy. Case courtesy Cheryl Sato, MD, Brigham and Women's Hospital. Mucinous cystic neoplasm affects middle-aged women and has therefore been nicknamed the mother tumor. It is benign but does have malignant potential, so treatment is typically resection. The tumor consists of a single or a few large cysts, less than 6 cysts that are greater than 2 cm, and typically occurs in the pancreatic body and tail. MCN has a capsule. When calcifications are seen, they tend to be peripheral. Serous Cystenoma. Serous Cystenoma in 2 different patients. Axial oral contrast only CT, left image, shows a large multicystic pancreatic mass containing central stellate calcification, yellow arrow. Axial T2 weighted MRI, right image, shows a T2 hyperintensity multicystic mass in the pancreatic head with innumerable thin internal septations, red arrows. Left case courtesy Cheryl Sato, MD, Brigham and Women's Hospital. Serous Cystenoma is a benign tumor that occurs in elderly women and has been nicknamed the grandmother tumor. Serous Cystenoma consists of many small cysts greater than 6 cysts that are less than 2 cm that can appear as a bunch of grapes, or may have a solid appearance on CT due to apposition of many cyst walls. MRI is useful to show the cystic nature of the lesion. Classic imaging feature is a central enhancing scar with stellate calcification. Comparison of solid pseudopapillary tumor, mucinous cystic neoplasm, and serous cystenoma tumor age mnemonic features. Solid pseudopapillary tumor SPT, daughter, SPRI, goes to spin class. Plus capsule. Cystic and solid, mucinous cystic, neoplasm MCN, mother, motherly, plus capsule cystic. Serous cystenoma grandmother, senile, SSTENLLTAARTAELCNIT, ALA, closing parenthesis, TEONNHANCUINNCGA. Intraductal papillary mucinous neoplasm, IP. Intraductal papillary mucinous neoplasm, IPMN. Intraductal papillary mucinous neoplasm, IPMN, occurs most commonly in elderly males and is nicknamed the grandfather tumor, although these tumors exhibit the greatest age and sex variability of the cystic pancreatic neoplasms. IPMNs are considered premalignant neoplasms and also increase the risk of developing a primary pancreatic adenocarcinoma, so these lesions are followed to ensure stability. IPMNs may arise from the main pancreatic duct, MPD, or a side branch. The main duct and mixed-type IPMNs have greater malignant potential. Main duct IPMN, branch duct IPMN, mixed type. Definitions: M, E, P, G, D, M, greater than, E, 5, N ta M, L, M, or diffuse dilatation of T, C, H, Y, E, S T S, M, greater than, P, 5, D, communicating with meets criteria for both main duct and branch duct type. Illustration. Main duct IPMN, axial left image, and coronal right image T2 weighted MRI in a patient with history of chronic pancreatitis shows pancreatic atrophy and main duct dilation arrows. This was found on pathology to be a main duct IPMN. Intraductal papillary mucinous neoplasm, IPMN, continued. The Fukuoka Consensus Guidelines 2017 for IPMNs and MCNs recommend imaging with CT or MRI for cysts greater than 5 mm. Further evaluation with either endoscopic ultrasound, EUS, or resection is recommended based on the following imaging features. Worrisome features should be evaluated by EUS. Cyst is greater than or equal to 3 cm. Enhancing mural nodule less than 5 m. Thickened enhanced cyst walls. MPD 5 to 9 m. Abrupt change in the MPD caliber with distal parenchymal atrophy. Lymphadenopathy. Elevated CA 19 to 9. Rapid rate of cyst growth greater than 5 m over 2 years. High-risk stigmata should undergo resection without further testing. Obstructive jaundice. Enhancing mural nodule is greater than or equal to 5 m. MPD is greater than or equal to 10 mm. Pancreatic endocrine neoplasms. Overview. Pancreatic neuroendocrine tumors may be hyperfunctioning or non-hyperfunctioning. Hyperfunctioning tumors come to clinical attention due to symptoms of endocrine excess. Non-hyperfunctioning tumors tend to be larger at diagnosis. These tumors may undergo cystic change and should be considered in the differential of a cystic pancreatic neoplasm. There is often central necrosis and calcification in these large tumors as well. Pancreatic endocrine tumors tend to be hypervascular and are best seen in the late arterial phase. Most are solid unless very large in size. A hypervascular liver mass with an associated pancreatic mass is most likely a metastatic lesion from a pancreatic endocrine neoplasm. Insulinoma. Insulinoma is the most common pancreatic endocrine tumor. Due to symptoms of hypoglycemia, insulinomas tend to present early and have the best prognosis of all neuroendocrine tumors with only 10% demonstrating malignant behavior. The Whipple triad describes the clinical symptoms of insulinoma: hypoglycemia, clinical symptoms of hypoglycemia, and alleviation of symptoms after administration of glucose. Gastronoma. Gastronoma is the second most common pancreatic endocrine tumor. Liver metastases are present at the time of diagnosis in 60% of patients. Zollinger-Ellison syndrome is a clinical syndrome that occurs secondary to a gastronoma. Hypersecretion of gastrin leads to gastritis, diarrhea, peptic ulcer disease, and even gastroesophageal reflux disease. Gastronoma is associated with multiple endocrine neoplasia, MEN type 1, and in this case tends to be multiple and located in the duodenum rather than the pancreas. Gastronoma continued. The gastronoma triangle describes the typical location of gastrinomas in an area bounded by the junction of the cystic duct and CBD, the duodenum inferiorly, and the neck body of the pancreas medially. 3 junctions of gastronoma triangle. 1. CBD and cystic duct. 2. Pancreatic neck and body. 3. Second and third portions of duodenum. 1, 2, 3. High gastrin levels can lead to formation of carcinoid tumors in the stomach, which may regress after the gastronoma is resected. Other pancreatic endocrine tumors. Glucagonoma is the third most common pancreatic endocrine tumor. Patients may present with migratory rash, diabetes, and glossitis. They have a high rate of malignant behavior, approximately 80%, and 50 to 60% have liver metastasis at diagnosis. Prognosis is poor. Lymphoma, vasoactive intestinal peptide, is a rare pancreatic endocrine tumor. Patients may present with profuse watery diarrhea and hypokalemia. Most are malignant and 60 to 80% have liver metastasis at diagnosis. Somatostatinoma is very rare. Patients may present with abdominal pain, diarrhea, and impaired glucose tolerance. 50 to 75% of patients have liver or lymph node metastasis at diagnosis. Systemic diseases that affect the pancreas. Pancreatic lymphoma. B-cell lymphoma is the most common subtype of lymphoma to affect the pancreas. There is almost always associated adenopathy and multi-organ involvement by the time the pancreas is involved. The typical imaging appearance is of a homogeneously, diffusely enlarged gland without ductal dilatation, with associated lymphadenopathy. More aggressive types of lymphoma may show heterogeneity, central necrosis. Von Hippel Lindau. Von Hippel Lindau is an inherited multisystemic disease which confers increased risk of multiple malignancies and leads to formation of cysts in various organs including the pancreas. Pancreatic neoplasms seen in von Hippel Lindau include serous cystenoma and pancreatic neuroendocrine tumors. Cystic fibrosis, CF. Axial unenhanced CT in a patient with cystic fibrosis shows complete fatty replacement of the pancreas arrows. Cystic fibrosis, CF, is the most common cause of childhood pancreatic atrophy. CF can cause either fatty atrophy of the pancreas or pancreatic cystosis, diffuse replacement of the pancreas with innumerable cysts. Schwakman Diamond. Schwakman Diamond is a rare inherited disorder characterized by diffuse fatty replacement of the pancreas, resultant pancreatic exocrine insufficiency, neutropenia, and bone dysplasia. Schwakman Diamond is the second most common cause of childhood pancreatic atrophy. Obesity and exogenous steroid use. Both obesity and steroids can cause fatty atrophy of the pancreas. Miscellaneous pancreatic lesions. Intrapancreatic accessory spleen. In phase MRI. DWI. ADC. Arterial phase T1 weighted. Portal venous phase T1 weighted. T2 weighted. Axial MRI images show a T1 hypointense, mildly T2 hyperintense mass in the pancreatic tail arrows that completely follows splenic signal intensity on all sequences, consistent with intrapancreatic accessory spleen. Intrapancreatic accessory spleen is a benign mimic of a hypervascular pancreatic neoplasm. Intrapancreatic accessory spleen continued. On imaging, an intrapancreatic spleen typically is a small 1 to 3 cm, well-defined mass usually found in the pancreatic tail. It follows the density, signal intensity, and enhancement of the spleen on all CT and MRI sequences. MRI is usually diagnostic. Either technetium-99 sulfur colloid or technetium-99 damaged RBC scintigraphy can confirm the diagnosis in ambiguous cases. Pancreas. Common imaging patterns. Hypervascular lesions. Neuroendocrine tumor. Metastasis, usually renal cell carcinoma. Intrapancreatic accessory spleen. Pseudoaneurysm, often seen after pancreatitis. Cystic lesions. Cystic fibrosis. Von Hippel Lindau. Pseudocyst. IPMN. SPT, MCN, and Serous Cystenoma. Diffuse enlargement. Acute pancreatitis. IG4-mediated autoimmune pancreatitis. Immunotherapy-related changes. Lymphoma. Atrophy. Age-related. Immunotherapy-related changes. Chronic pancreatitis. Metabolic syndrome. Fatty infiltration. Cystic fibrosis. Exogenous steroids. Obesity. Schwakman Diamond syndrome. Spleen. Congenital splenic variations and anomalies. Splenial accessory spleen. Also called an accessory spleen, a splenial is a focus of normal splenic tissue separate from the main body of the spleen due to embryologic failure of fusion of the splenic anlage. The most common location is the splenic hilum. Although usually an incidental finding, the presence of a splenial does have significance in certain clinical CTTings. For instance, splenectomy for consumptive thrombocytopenia may not be curative if there is sufficient unresected accessory splenic tissue present. A splenial may be mistaken for a lymph node or mass when in an unusual location. As previously discussed, an intrapancreatic splenial may be mistaken for a hypervascular pancreatic mass. A splenial should follow splenic tissue on all MRI sequences. If in doubt, a TC-99 sulfur colloid scan or a heat-damaged TC-99 RBC scan can be confirmatory. Polysplenia syndrome. Polysplenia syndrome is a spectrum of anatomic disorders characterized by some degree of visceral heterotaxia in addition to multiple discrete foci of splenic tissue. Multiple spleens may be located on the right or left but are always on the same side as the stomach. Polysplenia is usually associated with severe congenital cardiac anomalies. Most patients die in early childhood, but a few may have only minor cardiac defects and polysplenia may be incidentally discovered in adulthood. Polysplenia is associated with venous anomalies including interruption of the IVC with azygous or hemiazygous continuation. A less common association is a preduodenal portal vein. Wandering spleen. A wandering spleen is a normal spleen with abnormal laxity or absence of its fixed ligamentous attachments. Wandering spleen may present clinically as an abdominal mass or may cause acute abdominal pain secondary to torsion. Axial left image and coronal right image contrast-enhanced CT demonstrates a normal-sized spleen arrows in the left pelvis, consistent with wandering spleen. There are no findings to suggest torsion. Overview of splenic lesions. PSCS equals pleomorphic spindle cell sarcoma, previously malignant, number 1F Bruce histiocytoma or MFH. SON equals sclerosing angiomatoid nodular transformation IMT equals in number 1E amatory myo, number 1F broblastic tumor EMH equals extramedullary hematopoiesis. The above are rare splenic neoplasms not covered in this textbook, but included in this list for completion. Cystic and solid. Cystic. Infectious in number 1F amatory solid. Hypervascular. Non-hypervascular. Hamartoma. Castleman's disease. Sarcoma lymphoma. MFH metastasis. Epithelial cyst. Lymphangioma. Pseudocyst hydatid cyst. Cystic splenic lesions. Cystic lesions in the spleen are overwhelmingly benign in nature. Congenital true epithelial cyst. Splenic epithelial cyst. T2 weighted MRI with fat saturation, left image, and enhanced T1 weighted MRI, right image, shows a large T2 hyperintense, T1 hypointense, non-enhancing structure, arrows replacing nearly the entire splenic parenchyma. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. A congenital true cyst is defined as having an epithelial lining. Interestingly, a splenic epithelial cyst may cause elevation of tumor markers including CA19-9, CA125, and C, despite its completely benign nature. Unlike a post-traumatic pseudocyst, a true cyst may have septations, but mural calcification is uncommon. Post-traumatic pseudocyst. A post-traumatic pseudocyst is the end result of evolution of a splenic hematoma. Unlike a true epithelial, splenic cyst, the periphery of a pseudocyst is not cellular but made of fibrotic tissue and septations are uncommon, but there may be mural calcifications. On imaging, a post-traumatic pseudocyst appears as a well-circumscribed, fluid-density lesion with no peripheral enhancement. Intrasplenic pancreatic pseudocyst. A post-pancreatitis pancreatic pseudocyst involving the tail of the pancreas may extend into the spleen. Unlike a true congenital cyst, it lacks an epithelial lining and histology more closely resembles a post-traumatic pseudocyst. Splenic rupture has been reported in some cases of intrasplenic post-pancreatitis pseudocyst. Lymphangioma. Splenic lymphangioma is a rare, benign neoplasm usually diagnosed in childhood, which may be solitary or multiple. Lymphangioma features a classic imaging appearance of a multilocular cystic structure with thin septations. Post-contrast images may show septal enhancement. Benign non-cystic splenic lesions. If a mass is found in the spleen and the patient has no history of widespread malignancy or symptoms referred to the left upper quadrant, the mass is most likely benign. Hemangioma. Multiple splenic hemangiomas. T2 weighted left image and post-contrast T1 weighted right image MRI shows multiple T2 hyperintense splenic lesions, arrows, that demonstrate subtle peripheral enhancement. Hemangioma is the most common benign splenic neoplasm. They may be solitary or multiple and they tend to be small. Splenic hemangiomas are associated with Kasabach-Merritt syndrome, anemia, thrombocytopenia, and consumptive coagulopathy, and Klippel-Trenaunay-Weber syndrome, cutaneous hemangiomas, varicose veins, and extremity hypertrophy. These visceral hemangiomatosis syndromes are usually associated with phleboliths. On CT, hemangiomas are typically eyesore hypotenuating pre-contrast and hyperenhancing. On MR, hemangiomas are typically hyperintense on T2 weighted images and may enhance peripherally or homogeneously. However, the classic pattern of discontinuous nodular enhancement seen in hepatic hemangiomas is uncommon. Nuclear medicine scintigraphy with Tc-99 meters labeled red blood cells would show increased activity within the lesion on delayed images. In contrast, Tc-99 meters sulfur colloid scanning may show either increased or decreased activity. Hamartoma. Splenic hamartoma. T2 weighted left image and arterial phase enhanced T1 weighted right image MRI shows a vague T2 isointense splenic mass, arrows, that enhances heterogeneously. Splenic hamartoma is a rare, benign lesion composed of malformed red pulp elements. It may be associated with tuberous sclerosis. Splenic hamartoma is typically a well-circumscribed, eyesore hypotenuating mass on unenhanced CT that enhances heterogeneously after contrast administration. On MRI, a hamartoma is isoto-slightly hyperintense on T2 weighted images, featuring heterogeneous early enhancement and relatively homogeneous delayed enhancement. Inflammatory splenic lesions. Sarcoidosis. Sarcoidosis is a systemic disease of unknown etiology characterized histologically by multiple nodules